Started. Good morning, everyone. So today we have Dr. Zarin Noor, who's joining us. She's a pediatrician at UCSF Benioff Children's Hospital in the primary care clinic. She's also the director of the International Clinic, which focuses on the medical care of both pediatric immigrants and refugees. And she's also the associate program director for the Benioff Children's pediatric residency program. Where she has the opportunity to mentor and teach students and residents and kind of the up and coming next generation. She has a United States Civil Surgeon designation and provides medical examinations for immigration purposes, and is the co-director of the Center of Excellence for Immigrant and Child Health and Wellbeing. So we're very lucky and fortunate to have her today. And I will let you take it away. Zareen, I can
Okay, sounds good. Thanks. Hi, everybody. Good morning. Thanks for joining so early in the morning. I am going to talk a little bit about our asylum clinic and asylum medicine and ways pediatricians and pediatric clinicians can kind of advocate for immigrants. I'm going to share my slides. Give me 1 second. Put this up. All right, so hopefully you guys are seeing, what are you guys seeing my slides? Yeah, it looks good. Okay, perfect. All right, so let me just go to the objectives today. So this morning, we're going to talk a little bit about how medical professionals and pediatricians specifically can advocate for asylum seekers and can understanding our role in performing forensic medical and psychological evaluations, describe some of the clinical skills you can gain from performing forensic medical evaluation, and then, really kind of think about the impact of human rights clinic for asylum seekers. And we'll talk a little bit about our human rights cooperative, which I think some folks might know and have experienced. So just before, I know it's early on a Thursday morning, the topic is hard, it's difficult. So if this is too much, you need to take a moment, you can feel free to step away, turn off your camera or whatever you need to do, or take a moment, because it is hard. This topic is kind of heavy, so just take care of yourself. And then afterwards, if you need to debrief or I'm always available. You can give me a call or email me or whatever. We can talk. And I know we all have our own traumas and our own experiences. And some folks have their own immigration experiences, and this can be difficult. So just giving you a little heads up. All right. So just to give a broad view of what's happening in this world, the number of people who are being forcibly displaced has been creeping up. And it's really, I've been doing this talk for a few years, talks about immigrants over the past, I have 8-10 years now. And it's amazing because every year I try to find the most recent data, and this number keeps creeping up higher and higher. I mean, I was looking back at my old slides, trying to, get some slides, and I was there was one where it was 80 million people forcibly displaced. And now it's close to 120. So definitely there's an increase of people being forcibly displaced for multiple reasons. And hopefully during this week seminar, you are hearing some of, some components of the reasons for this kind of forcing people to migrate and move and leave their homes. But right now there's just at the end of 2023, and my prediction is it's probably going to be higher once they have the 2024 data. So, but there's a lot going on in the world and a lot of reasons why people are being forcibly displaced. So if we were looking at all the migrants in the world right now, if there were one country today, it would be the 5th largest country. And so it's a huge number of people being forced to move or moving, actively moving. So it's a big population, and one that, and I think this is kind of the reason why in global health, immigrant health, border health, all of these things are kind of merging, because there's so much movement happening. So just to lay some groundwork of kind of the terms, I don't have all the terms here, but just the terms that I might be talking about today, just to give you some background. There's the migrant. That's someone who leaves their home country. Often, it's because they're seeking an economic opportunity, or there might be some climate change or things that are, they're unable to be protected by their government, and so they're choosing is the word choice is sometimes it's not always a choice, but they are leaving their home. A refugee is someone who has fled human rights violation or persecution in their home country and has a reasonable fear that returning would be unsafe, and they get granted a protection status by international law outside of the US. So this is a very specific term that is put out by the UNHCR, and this designation has to be given outside of the US in order to have that refugee status within US. So when you are working with refugees, they have gotten that designation outside of the US, and they are here, and we are their host country, and they're called a refugee. Asylum seekers are someone who has similarly also fled because of persecution, just like a refugee, but they're inside the US, or they're at the port of entry. So they're at the border, or they're somewhere that they're entering into the US and applying for protective status from our government. So those are people who they're coming in and saying, I can't go back home. For the same reasons that, refugees, they're being persecuted, their human rights are being violated, but they are applying here inside the US. And so those are asylum seekers. And if they are granted asylum, they are referred as asylees. So a little difference between a refugee and an asylum seeker or asylee. So just to be, and if you have questions, we'll have some time at the end, and feel free, or put it in your chat and we can talk. All right, so seeking asylum is a human right according to the Universal Declaration of Human Rights. But to get to that safety net asylum, the asylum seeker bears the burden of proving that they meet the criteria. So it's really up to them to prove that they meet these criteria that were set by the 1951 Refugee Convention. They have to prove that they're unable to return to their home and be protected by their country. So and it's usually because of these specific conditions. So either they're being persecuted on account of race, religion, nationality, political opinion, or particular social group, which is a broad kind of term. And a lot of things kind of fall under that particular social group, whether you're like an indigenous, from an indigenous community, have LGBTQ status, different things can be considered under the social status. But there, even though this is, the statement that seeking asylum is a human right. There's a lot of policies and laws that are being enacted that's really undermining this and really making it difficult for asylum seekers and putting a lot of barriers for asylum seekers to seek asylum in the US, and it's become a very political thing, and we can talk a little bit more about that. All right. So we're going to do a little case, and then we can, we're going to weave this case in throughout the talk today. So this is a case that we saw in our asylum clinic, and I'll talk to you about our asylum clinic, but this is one case that we had. It was a 17-year-old male from Colombia. At the age of 12, he came out to his family and his friends that he was gay. But he quickly realized that being gay in Colombia was dangerous. He started getting bullied at school. He talked to his school, his teachers and the school psychologists, and they kind of, told him, oh, it's just kids being kids, and that he's making up a lot of what he's experiencing, and he should just kind of focus on his school. When he got into high school, he was the specific target of a student who had family members in the paramilitary group that had control of their neighborhood and their area. So under her kind of, guidance, her friends would push him, berate him, damage his school materials. He at one point was attacked and hit with a metal stick and punched in the face. This led to a lot of mental health conditions for him. He developed anxiety, depression, he had anorexia, started cutting himself. And during this time, he had a lot of hospitalization for his mental health. He had at some point had to do online school because it just became so severe. At one point, his parents started getting targeted as well, and they would leave notes saying it's because you need to get your son treated. Because of him being gay, and so at one point he got so frustrated that he posted an online comment about that student. And after that incident, the situation got significantly worse. His mother began receiving anonymous calls threatening to destroy her family food business. And then the father started receiving really threatening calls, and the calls started to increase in frequency, and the family was forced to leave Colombia. All right, so for this client and many clients who are seeking asylum, again, like I said, the onus is on them to prove that they cannot return home and that they have experienced the persecution. And so we know that there's one study that showed that asylum seekers who go through the asylum process without a attorney representation have a 15% chance of getting their asylum approved. This increases significantly if they have an attorney representation, so it goes up to 45%. And then if they have a medical evaluation, a forensic medical affidavit, in addition to their attorney representation, their chances of getting granted asylum increases to 85%. So it makes a huge difference. This forensic and medical evaluation that we're going to talk about makes a huge difference. All right, so many flee persecution, only have their narrative accounts and the scars on their body and minds to attest to the horror that they have endured. And we as healthcare professionals, as clinicians, can provide objective documentation of the physical injuries and psychological traumas as evidence to corroborate a narrative of persecution. So we really can play a role by doing these histories and physicals to document the evidence of physical injuries and psychological traumas to corroborate their narrative. And it makes a huge difference. So as a response, there were very motivated and wonderful medical students who worked with physicians from several departments, clinicians from different departments, to create the Asylum Clinic, which is called the Human Rights Cooperative. And it is under the UCSF Health and Human Rights Initiative, which is multi-departmental group who is really working on kind of building out the asylum evaluation and then doing a lot of training and education around asylum medicine. So our mission is to really provide forensic documentation of the physical and psychological manifestation of torture and ill treatment experienced by individuals applying for asylum in the United States. And the reason we're doing this, and some reason why I'm talking to you all, is that we we all have the expertise and skills to do these. This is not something, this is within your scope of skills that you've developed as pediatricians. And the reason why I'm talking is because there's a huge demand for these evaluation, and it really exceeds the number of clinicians who are prepared to conduct the Asylum evaluations. So there have been different groups. There's been a clinician's guide that's been put out around asylum medicine. And then there's the Society of Asylum Medicine that's really helping increase the number of people who can do these evaluations through their trainings. So what is a forensic medical evaluation? So what are the components of it? One is the interview, which can be very in-depth. And again, this is not a medical evaluation, right? You're not trying to this is not like a well-child visit or anything. Like, this is very specific about eliciting a narrative of the reported abuse or trauma that they've experienced. And so it can be very in-depth interview about kind of what has happened to them. It includes a psychological assessment, and we'll go over some of the tools that we use. And then depending on whether there are physical findings, scars, or injuries, there might be a medical assessment as well. All of this is documented in affidavit, at the end, you are writing an impression of the consistency of the medical and psychological findings with the trauma that was described. And I'll go in detail about the language that we use around that. The Human Rights Cooperative was started in San Francisco, and it was mostly adults in that clinic. We saw a lot of adults, but over time we were seeing that there was a lot of minors seeking this type of evaluation. And part of that reason is we've been seeing an increase in unaccompanied minors over the past 10 years. Oftentimes the children's cases were linked to the parents' application, and so the parents would get the evaluation. But over the past, I would say the past 10 years, more so the past 5 years, there's been an increase in the number of young adults and young children coming in unaccompanied. And so they themselves need to have this evaluation done. And as a response to that kind of need, we developed the pediatric arm, like the Pediatric Asylum Clinic, which is one of very, very few pediatric specific asylum clinics in the US. There's only a handful of them. There aren't that many pediatric specific ones.
We have 2 questions in the chat. Okay to interrupt?
Yes, please.
Thanks. So Jasmine asks, so if you were doing an evaluation for a pediatric patient, can you also assess the older family members at the same time, or do they have to go to a separate adult clinic?
So we coordinate with our adult providers, the adult clinic. And so we try to do it either in tandem or like I did a case recently where I did the daughter's case, and then there was an adult provider who did the mom's case. And we talked beforehand to kind of strategize about what information we needed to gather. And then we talked afterwards, after each evaluation separately. The young woman was a little bit older, so I was able to do it separately. Sometimes if the child is young, and just to limit the amount of trauma that the parent is also experiencing and retelling the stories, sometimes we'll do it together. And so we try to coordinate with the adult provider, or we have one of our family medicine colleagues do both the parent and the child together, so that they can get all the information. So we coordinate with them, and we talk a lot amongst ourselves to kind of minimize the trauma for the family, and also kind of make sure that we're providing the right kind of evaluation, whether if it depending on the age and the situation. Yeah, the second question I'm just reading, can it be damaging to asylum seeker case to do a physical exam if there's no current abnormal find? Yes. It depends. If there's no physical findings, we won't do the physical exam. These cases are referred to us by attorneys. So the attorneys determine whether a evaluation, a medical psychological evaluation, would be beneficial to their case. So we don't determine that. So we work with the lawyers, and so we talk. Part of the process is, before we even talk to the client, is to talk to the lawyers. Will submit the referral. They'll tell us what they're looking for. We meet, when we get assigned a case, we meet with the lawyer. We talk to them. What are you looking for? What is it that you want out of this evaluation, right? What do you want me to focus on? And so we do that. And then when we do our affidavit, we send a draft to the lawyer for them to look at, to make sure there's there's consistency with what they, their case, and so that we're not jeopardizing their case at all. So yes, we work closely, and we try to, our utmost goal is to decrease the trauma for these. We try to be trauma informed, so we try to decrease the trauma for them, and then two is really try to help their case, not hurt their case. So yeah, good questions. All right, so why do we want to do a pediatric specific clinic? Is because we know, right? I'm talking to why you guys know kids are not little adults. They're very different. We know that children are more vulnerable to some types of persecution. And so, these are some of the forms of persecutions that they are vulnerable to. They're traffic, there's sexual violence, sexual gender identity discrimination, female genital cutting, and then recruitment into gang-related activities. It's a lot more recently that's been an issue, and they might be deprived of food and medical treatment. And so what we kind of focus on in our pediatric asylum clinic is really creating a comfortable environment. And that's why we do it at our Oakland clinic, and hope some of you will all come on Saturday and get to see how we do it. So we do it in a pediatric clinic because it's right. Pediatric clinics have pictures on the wall. This is a little bit more friendly. It's not an adult clinic can be a little, it's different. We do it on a Saturday, so the adult clinic is usually during the week in the evenings, and we know kids it's hard in the evenings and with school and everything, so we do that on a Saturday during the morning, so they're a little bit, it's a little bit more child friendly. It's important to take language, age, and development into account. And as pediatricians, we're able to do that. Maintaining cultural awareness, cultural humility is a cornerstone in our work. And then being trauma informed, all of this kind of goes hand in hand. We know that trauma can affect a child's capacity to form, recall, and narrate memories. So the memories that how children recall events can be different in the steps, and so sometimes we use different tools, visual tools, written tools, to help them kind of remember what happened. And then we also know as pediatricians that trauma stress can manifest differently in children, and we can speak to that right in our affidavit, and so it might not be the way an adult provider might see stress. We can see it manifest in different ways. We know that children express their thoughts, effects, and memories based on their age and their development, and as well as cultural norms and personality. And these are things that we like. This part of it, the family dynamics, personality, cultural norms, is is where cultural humility really plays a role in how we kind of, when we do these evaluations, how we talk to and gather our information, and how do we process it and understand how to express that in this affidavit for a judge to understand. We also, I think, as pediatricians, know that children don't always express their thoughts and emotion verbally, and sometimes it's behaviorally. And this is important when we do these evaluations, and talking to the caregiver as well as the child, to gather all the information about the traumatic events. Oops. Going back, trauma-informed care is really important. And we try to do this. I talked a little bit earlier about child-friendly environment, collaboration. We work really closely with the family, the lawyers, to really make sure that we are only gathering the information that we need, and not, we're not going to bring up things that is not necessary for their case, and to re-traumatize them. Expectation setting is really important, transparency. And so we do this in the beginning. We really talk about what's going to happen during the day, give them, so they know what's going to happen, and then give them some ownership in being able to take breaks and not talk about things that they're not ready to talk about. So that's super important. And then also, I think it's important for them to know that this is a forensic evaluation for their legal case, and this is not a medical evaluation. So we're not providing medical care. So we're not providing medication. We're not trying to, like, solve their medical cases. This is just to gather information, to write an affidavit to help their case. And it's important because it's oftentimes they say, oh, well, you're a doctor, and so you're supposed to give me medicine. So it's important that we set that expectation and explain that this is a forensic evaluation. Determine what part of the story is important to hear directly from the patient, right? And so we might not need to. They when asylum seekers are working with lawyers, they have to write what's called a declaration. So they write out exactly what has happened to them and why they're seeking asylum. So, and oftentimes it's written in their native language and translated into English by the lawyer. And so we have that declaration before we do this evaluation. So we have that, and then we also talk to the lawyer about what parts of this do you want me to focus on? What do you want me to talk about? So there might be a lot in their story and in what they've experienced, but we might not address all of that because, again, we don't want to re-traumatize them, and we don't need to. They already have their declaration. The judge already has that. So the judge doesn't want to just, repeat what has been said. They kind of want to know the effects of that trauma on the asylum seeker. So, so again, it's super important to have that conversation with the lawyer and have a conversation and determine, and we work together. So sometimes, like we'll talk to each other about, okay, I have this case, and how should I approach this? Should I, and we have a wonderful group of pediatricians, psychologists, social workers, psychiatrists, so that we can kind of really think about based on the child's age and development and their, how to kind of approach this in a way that's not going to re-traumatize them. A parent guardian involvement is important, especially if they're a minor under 18. And so, and we have to kind of see, sometimes we go into the situation thinking, okay, we're going to have the parent, and then we notice like the child is not talking when the parent is in the room. And so we need to kind of pivot and think about how to have that conversation with the child alone, because there might be some stuff that they've experienced that they don't want to, they don't feel comfortable sharing in front of their parents, or their parents might have been involved in some of that trauma. And so, or the parent themselves have, like, they're can't handle that, like retelling of the trauma. And so they're becoming visibly upset, and that's affecting the patient. So there's lots of things to kind of take into account. And so we often have to like really read the room and pivot. But we do try to have the parents involved and try to get their story, their side of the story, if possible. History taking is this part of it is really important. We have informed consent. So, and for minors, assent, we make sure that they understand what we're doing and that they're okay with having this evaluation. Sometimes some family patients come in and they don't know why they're there. The lawyers didn't really explain to them why they're there. And so it's important for us to kind of explain what the purpose of that visit is, and that they get consent, that they are okay with this evaluation. And then ongoing consent, right? So maybe you start this evaluation and they're like, I don't want to do this anymore. I'm done. Or like they don't want to take part in the physical exam part of it. So it's an ongoing consent. Are you okay if we talk about this? Are you okay if we do this part of the exam? So ongoing consent is important. Pauses and breaks, we emphasize this a lot with our providers, is like, it's okay to take breaks for yourself, for the client. And then also we have interpreters in the room. Oftentimes we have interpreters, and so giving our interpreters an opportunity to take pauses and breaks too, because it's a lot. There's a lot of vicarious trauma that happens. These stories are difficult, and so it's important to take pauses and breaks. And we have snacks, and again, part of being child friendly, we have lots of snacks. We have fidget toys for them. We have coloring things that they can do to help kind of make them feel comfortable. And then we have lunch as well provided. And so we try to take as many breaks and pauses. And then being mindful of space, where you're sitting, how we spend a lot of time in the morning kind of figuring out, okay, where should they sit? Where should you sit? What should your body be? Where should your body be? Where should your computer be? So that you're, again, mindful of your space, and also your interaction with and being kind of lower level, right? We all know this as pediatricians, right? Trying to be eye level, and our body language is super important. Open-ended questions, right? Tell me a little bit about, can you explain this a little bit more? Can you describe this? So again, being very open-ended, and then asking for clarification as needed, if you need it. So, all right. The psychological assessment, I think this is probably the hardest part, is the psychological assessment, because especially in children, and I think that's kind of why we really wanted to have a pediatric specific clinic, because we know that it's the psychological assessment can be very different depending on their developmental age. And we know that trauma can affect kids' psychological state in different ways. There are trauma can lead to fragmentation, right? We know this, right? And how that's manifested can be very different. And so sometimes we have clients who have a lot of intrusive experiences, or we've had clients who've had like true dissociation happening right in the clinic. There is some of them who will say things like, oh, bad things just happen to bad people. Their memories might be, like I said, they give us a declaration and they write all the trauma that happened. And then when they come talk to us, the sequences of those memories are off, and it doesn't really match the declaration. And then the lawyer the lawyer's like, well, that, and so you have to explain kind of why there might be non-sequential memories, and there might be sometimes traumatic amnesia that happens. So it's important to kind of take into account the child's developmental age, and their psychological assessment can kind of put it together. So that's an important part. The tools we use to kind of help us with this are ones that we use in clinic. So these are all tools that we are familiar with in clinic, and so hopefully you guys are familiar with this. Like, so the PHQ-9, I think all of us use this in clinic, which screens for depression. It is for children over the age of 11. GAD-7 is for anxiety, and it's 13 plus. And then we use the PSC-35, and this is like more to look at trauma, and it can be, there's a parent version, and then there's a teen version as well. So the patient themselves can do it, so depending on the age. And then there's the UCLA PTSD brief screen that has 11 items. There's a longer screen as well. Some providers use that if they need to, but there's a briefer version, which is 11 items, and it's usually the client themselves will fill it out. Sometimes we give the forms for them to fill out, and sometimes we do it together. So it depends whether they can read or write. All of these are in Spanish and English. We have some clients who speak other languages that there's no translation, so we use our interpreters to go over those questions. And then and also sometimes some of our clients don't read or write, and so they're not able to do it, or they have a hard time understanding the questions, and so it's important to go over those questions. And sometimes you get a lot more when we go over these. You get a lot more history. You get actually, they're like, oh, well, let me, and they start talking about something else that has happened. So sometimes we'll go and do these questions, which takes up a lot of time, but you can get a lot of information from it. There are other screening tools that can be used, but these are the ones that we kind of use in our clinic. But some, especially our psychology clinicians, they'll use other screening tools and other tools to help them with the psychological evaluation, and just need to, in your affidavit, explain why you use those tools and that they're validated tools. All right, so going back to our case, so he really, this young man really expressed little interest in, when we were doing his psychological evaluation, he expressed little interest and pleasure in doing things. He often felt down, depressed. He had trouble falling asleep. He felt really had low energy. He said that sometimes he would speak really slow and other people would notice that. And then he said, sometimes I just want to lay down. He had a lot of intrusive symptoms, a lot of repeated memories of the online statement he posted. And he had a lot of, he would question himself, would I still be in my country if I had not done what I did? What could I have done differently? And then he continues to dream about being beaten. And then he had, every time he passed kind of a group of young men, it re-triggered his thoughts of previous harassments. And so it really was affecting his mental health. In addition to the psychological evaluation, it's important to also document some protective factors, and to really kind of emphasize the positive impact of a safe environment. Oftentimes, what happens is when we do the PHQ-9s or GAD-7 and stuff, it's all negative. And, despite the trauma that they've experienced, when we ask them, currently, are you having these symptoms? And they're like, no, I'm fine. And again, it's those, and we know this, right? The protective factors are resiliencies, right? So they have being here in a safer environment has helped them manage some of those feelings. And so sometimes we'll ask those questions and be like, when you were in your home country, did you have these symptoms? And it would be very positive. But now they're like, well, I'm in school, I'm safe, I have friends, I'm away from my abuser, whatever it is. And now they're feeling okay. And so it's important to also document that, right? That they are the positive impacts of being in the safe environment and the potential and then we ask questions like, if you were back home, and then you document like, what are the potential consequences if they return back to their home, their country of origin. And so important to kind of document some of those protective factors and resiliencies. So for our client, he expressed that his improvement in his psychological symptoms since he arrived in the US. He says, everything just being here, I feel safe. He has goals and hopes for his future. He's in college right now and working. And then he has strong adaptive coping skills. So he helps support his family. He's in school right now. He has a group of friends and things that he's looking forward to. So it's really has helped him a lot. So documenting that is super important in the affidavit as well. So the physical exam part of it, not everybody needs a physical exam. Not everybody has scars. Not everybody has physical findings. And so sometimes it's just a psychological evaluation. Like the case that I presented, he didn't have any scars that were relevant. We did a physical exam just to make sure that there wasn't anything, but he didn't have any scars or anything that was concerning. So we didn't need to do any forensic photographs or describing of scars. In other cases, sometimes we do, right? So some clients will come in and they've been tortured or injured, and there are scars left from those traumas, and we have to document those. And it's important to do a thorough skin exam to identify some of those scars. And again, it's ongoing consent, right? Making sure they feel comfortable doing it, minimizing kind of the trauma. So we tend to do this at the end of the visit to make sure that they, feel comfortable. Draping is super important, making sure that they feel that they're covered up and you're only seeing parts of the, skin that you need to look at and kind of works systematically. And then also taking photos is important, but it's important to talk to them about what you're going to do exactly with those photos. And so what we do is we take the photos and we upload it in box and delete it from our devices. So it's like not, and we tell them exactly what's happening with their photos. And so it's important to, again, consent, making sure they're okay with it. But also, telling them that it's important because it can be very, very, very helpful. Because if they have true signs and scars of trauma that you can describe in your affidavit, it can be incredibly powerful and helpful in their case. So, oops. Oh, that's mine of its own. Okay. How would you describe this scar here? The one on the right, upper one. Your right and on my right, the one with the circles. And somebody, how would you describe this?
Like using medical terms or what we think caused it?
So you maybe describe it in medical terms first, and then maybe how would you describe it to a non-medical person? What does this look like to a non-medical person? Like describe it, the way it looks.
Jasmine's typing in the chat, but like discrete, circular. She also said grouped. It looks like it could be raised or a little like dry. It's a little hard to tell from the photo.
Good. Great. So yeah, you're right. Discrete circular lesions, right? Slightly darker around the edges, right? And yeah, a little scaly. I agree with you, Erin, a little scaly. Right? Okay. What do you think caused this?
Like cigarette burns.
Yeah, exactly. So this is very classic of cigarette burns, right? So you know, in our term, hyperpigmented circular lesion with, you know, central, almost a little bit of central clearing, a little bit lighter in the center, but it's very discrete circular. And this is very consistent with cigarette burns. How would you describe the bottom picture?
A linear hypopigmented scar, about like 6 centimeters.
Yeah. So yes, so a hypopigmented linear scar with narrowing right at the end, at the tail, right? What do you think caused this? So whipping, so it's very classic, so that there's the area of the most impact right here, and then there is the tail, right? The fishtail that usually happens from the other part of the whip. And so this is very classic of whipping that can happen. So there's a whole, like we can do a whole lecture on physical findings for asylum medicine. And a lot of the pictures, I mean, it's just like our child abuse kind of colleagues, and Dr. Stewart actually does a great talk around this and some of the physical findings. But there are a lot of training around how to describe findings, and then also kind of help you identify what the causes of those scars can be, what are potential causes of those scars. So there's a whole, there's a whole nother lecture that can happen, but just know that documenting these injuries and these scars are super important, and then the photos are super incredibly powerful, and you include those in your affidavit so that the judge can see those scars and understand, kind of follow you along with the why you're saying that this is caused by a certain like trauma. All right. And then also just to note, not all injuries present with dermatologic findings, right? A lot of, especially our kids, right, who their scars fade, right? Or they don't, there's no scars left behind after their trauma. And so that doesn't mean that trauma didn't occur to them, it didn't happen to them. It's just that there's no physical findings left. So important. All right, and then we conclude all of our evaluations, really focusing on, we try to talk about like, what are you going to do this weekend? What are some things you're looking forward to? So some positive things for them to, and we tell families and clients to really, like, it's a lot. What you've experienced, what you talk to us about is a lot, and we need you to, you know, we want you to take this time to kind of recenter and do something that brings you joy. And then we can give them sometimes coping tools such as deep breathing exercises, some tools around meditation. So we have social workers in our team who can help with families and just deal with some of the stresses. And then sometimes we have to consider a safety plan. It's a lot to retell all the trauma, and so it can it can trigger a lot for our clients, and so we have to be ready to develop a safety plan if necessary. And then we have Alejandra, who is one of our family navigators in our clinic, and she and we also have our medical students who do call the client after the evaluation to make sure they're linked into referrals as far as medical care and mental health care. And so we often we really help support the families to make sure that they get plugged in to either go back to their pediatrician or to get some mental health support. Some of them don't have any medical home, and so it's important that we us pediatricians want to make sure the patient as a whole is taken care of and that they're plugged in. And so we really spend a lot of time after the evaluation to make sure that they're plugged into the resources that they need. All right, so then you're done with the evaluation, you have all this information. So now what do you do, right? We use a REDCap application. So when you're in the room, you're filling out the REDCap and you're putting all the information in this REDCap. And then at the end, the REDCap is converted into a Word document. So all of it's written out for you with all the information that you've included in the REDCap. And then you go in and you edit it and you kind of add more narrative. And so the affidavit writing we've tried to decrease. Before we would have to go in, get all the information and just free write all of this information in there. And so now with the REDCap has really helped in our affidavit writing. The things that are important to include in your affidavit is the case information. So really like the client's information, their place of birth, all this information that's important for their case. Clinician's qualification, what makes you qualified to do this evaluation, right? You're qualified. You went through a lot of training. And so you write your qualification. I like graduated medical school. I've been, practicing the blah, 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 blah. I take care of patients, who are recently immigrated and refugees, all this stuff. So you write all your qualifications down. You write background information. You do about the case. You do a brief summary of the reported trauma, the physical symptoms. You write your physical exam. You add your photographs. You do your psychosocial history, any of the diagnostic tests if you needed to do, and diagnostic considerations. And then you can do your interpretations of your findings, and then conclusion and recommendations. And then you have to sign it. The interpretation of findings and conclusion recommendation this is the key part of the affidavit. So sometimes the judge will just skim. What is your interpretation of your findings is what they want to look at. And we do it based on the Istanbul protocol. So this is like the definitive kind of documentation and around asylum medicine. And so a lot of what we do is based off the Istanbul protocol. And the Istanbul protocol gives you language that you need to use in your affidavit. And the terms are your impression of what this trauma that this patient has experienced. So is it not consistent with, meaning that it could not have been caused by the trauma described. Consistent with, could have been caused by the trauma described, but it's not specific and there are many other possible causes. Highly consistent, could have been caused by the trauma described, but there are a few other possible causes. Typical of, usually found with this type of trauma, but there are other possible causes. And then diagnostic of, could have not been caused by any other thing than that cause. So for our case, right? He had psychological evaluation demonstrated that he suffered from depression, general anxiety disorder, symptoms of post-traumatic stress disorder. The source of these disorders originated during his elementary school and high school, and is due to psychological, verbal, physical abuse he experienced due to his sexual orientation. In my clinical opinion, the overall findings are typical of, right, usually found with this type of trauma, but there are other possible causes of the trauma he experienced. Okay. So this is the type of language that the judge wants us to hear at the end of the affidavit. You're running low. Okay. You want to get involved? There's ways of doing this. There is an online training through the Asylum Medicine Initiative that our team has helped develop, and there's a pediatric specific one too. There is a resident asylum medicine elective that you can do if you're really interested in it. And it was, there's some online didactics, there's small group discussion and hands-on experiences, and you'll be able to come into clinic and do an evaluation with us. And so hopefully by the end of your residency, you'd be trained and ready to do these evaluations on your own. So there's 5 self-directed interactive online modules. You participate in 5 virtual case-based small group discussions, and then you complete 3 forensic medical evaluation under our supervision over time. It can happen throughout your residency. If you're interested in it, you can reach out for pediatrics. You can reach out to me or Raul Gutierrez in San Francisco. So either one of us you can reach out to, and we can kind of help you get connected to that. I just wanted to give some time to ask questions and stuff. So yeah.
How long are each of these visits?
They're long. So we do it on Saturdays. It starts around, we get there around 9:30ish or so. The evaluation starts around 10 and can go up to like 1, 2 o'clock. So it's like a 3-4 hour evaluations. Mm-hmm.
What advice do you
I
have?
saw there was an emergency medicine contact.
I'm sorry?
Oh, no, go ahead.
The emergency medicine contact is Teresa Chang.
Delayed.
Oh. Sorry, I think there's a delay in the. I'll put the.
I was going to ask Zarin, what advice do you have for pediatricians who want to do this work and are just getting into it? So, for example, for our residents who will be joining you on Saturday, how can they best kind of mentally prepare, and what kind of like general advice you have going into their first asylum exams or evaluation?
So on Saturday, you'll just come, we'll give you more of a tour of the clinic, and you can hear about the 2 cases that we're doing, and kind of like you'll see the process of kind of how we do it. You will, unfortunately, given the sensitivity of these evaluations, we can't have you shadow. But if it seems like an interest for you and you want to do it, we can definitely get you to come in and shadow a case in the future. I highly recommend doing the online asylum training first, because it gives you a lot of, I'll put it in here, a lot of background, like it gives you a lot of information around asylum medicine, and so you'll know what you're going into. Yeah, that's definitely how and if you're interested in just kind of like figuring out more, we can talk more about it. Oh, I see. So it has to be planned. There's no, again, the lawyer has to determine whether this evaluation is helpful or not. And it's not going to happen in the emergency room, right? Because you're going to be trying to deal with. However, your documentation can be super, super, super important, because if you document certain injuries in you know, in your that we can use that. We can use those medical records and be like, you know, this patient went to the ER and got treatment for this, you know, and like we can use your note, definitely. So it's important in your documentation and to also put your clinical, like, fine, like I think this looks like such and such, or you know, so that helps a lot with the cases. So sometimes the lawyers will just use those ER notes rather than getting a full evaluation.
To follow up on Jasmine's question, how, if you have a patient that come in and you suspect that, or they disclose to you that they're seeking asylum, what community resources are available that we can refer them to? How do we get them looped into the system so they can find a good lawyer? Like, how do we help facilitate that?
Yeah, so I think unfortunately there's a huge wait list for immigrant lawyers, you know, and so it's been very, very difficult, but it's important to use some of your community legal groups to help with cases. And so East Bay Community, at least in the East Bay Community Law Center has a good website, and it has lists, and it also has San Francisco immigrant groups. And so you can give them that list. Most of our social workers and family navigators are familiar with kind of our immigrant population and can help get families connected to a legal representation. But the first step is actually legal representation. And this is like a plug for medical legal partnerships, right? This is where those medical legal partnerships are so, so important. Because if you have those, if clinics have those, as health systems have those, that can be a huge, you know, that will help significantly, right? Not just their medical care, but also like all the social determinants, the social drivers of health. Yeah.
Well, thank you so much, Zarin. We're at time. I just want to say thank you for your time, and it's always a really enlightening, important topic to cover. We've also put a link in the chat for a brief survey, 3 questions only for everyone who's on. If you don't mind just taking a quick minute to fill that out, we really do appreciate your input and feedback.
Yeah, and then feel free, for those who want to come on Saturday, feel free to come. We do have Nicholas Holmes, Dr. Holmes from the president of the BCH. He's going to come and tour as well. So there's going to be a full house, but it's going to be great. We have 2 wonderful cases that's going to be happening, and so you'll get to meet our med student team and stuff. So feel free to come on Saturday.
Oh, thank you so much. Really appreciate it.
Yeah, of course.
All right. We'll see you later.
Thanks, everybody.
Bye.